All right. In the interest of time for everybody, good evening, everybody. I'm Michael Bond. I'm the current president of Maryland ACEP. I thank you for joining our town hall. This town hall is specifically to address HED and the Medicare CMS waiver that Maryland has to see where we might be headed in the future. I'm going to turn things over to the president-elect, Dr. Kerry Forrestal, who will be our master of ceremonies.
All right, good evening, everybody. Thank you for coming out. Thank you, Mike. So I am Dr. Kerry Forrestal. I'm the president-elect, and welcome to this town hall for the Maryland chapter of ACEP. In our last one, we had Gene Ransom and Dana Kaufman talking about legislative issues that are of impact to emergency medicine. And our next, we'll be talking resolutions, that'll be or so, resolutions to guide ACEP on national policy. But tonight we have Jonathan Kromm, PhD of our own Maryland Hopkins Bloomberg School of Public Health Policy. As many people know, we're changing over on the waiver. There's been a lot of discussion and a lot of misconception about that. And we're moving ahead to what's called the AHEAD model, which is advancing all payer health equity approaches and development. So recent legislation has obviously made that somewhat more nebulous, what's going to happen. So we asked Dr. Kromm to come on and help us sort through that. And without further ado, Dr. Kromm.
Thank you, Dr. Forrestal. It's a pleasure to see you all. I didn't realize that I was following Gene and Dana. That's a tough follow. So, so I'll try my best here. It's good to see everybody, and thanks for inviting me to speak on this important topic. Right off the bat, let me level set that we are in a very kind of fluid moment in time regarding the AHEAD model. So as Dr. Forrestal mentioned, right, last year we had signed and really entered into a state agreement with the federal government on the AHEAD model. The AHEAD model is undergoing some changes, and so we are in the process of essentially renegotiating our agreement with the federal government there. So I will kind of give a status update on where we are in the moment at this moment in time. But let me start with what the AHEAD model was, what it was intended to be, and hopefully continues to be, and then why we would want to be in this model, right? So just a couple slides here. I won't go through very much, but the AHEAD model essentially has a few components, right? It provides some waivers to Medicare payment. That is the primary kind of thing that the state gets, right? It gets some flexibility around Medicare payment, but it establishes some accountability targets for the state as well. Namely, and most importantly, there is a total cost of care growth target, or you may hear about it as the savings target. That's kind of what we've called it for years here in Maryland. There are a couple core elements within it, hospital global budgets being a central one, as well as the primary care AHEAD aligned primary care model. The AHEAD model really does functionally build off of the total cost of care model, hospital global budgets being at the center. We have done a lot of work and investment over the years, particularly on managing a value-based program for primary care called MDPCP. And speaking of Gene is very involved in MDPCP and the physician practice program that is kind of on a similar basis aligned with that called EQIP. And then beyond that, there are a number of population health and health equity initiatives that we have established under the total cost of care model that are intended to continue under the AHEAD model. I'll come back to the health equity component of that in a bit. But really, why AHEAD, right? I mean, the total cost of care model has done some good things, and I will kind of describe a lot of the benefits that it has had for the state, but it isn't certainly not perfect, right? It needs to evolve, and there are challenges associated with, as with every state, there are challenges associated with our our healthcare delivery system as a whole. But the AHEAD model is really the pathway to secure continuation of the Maryland model. And so let me talk through a couple kind of benefits of the total cost of care model and what we would seek to preserve in the AHEAD model. So under the total cost of care model, we have done quite a bit on affordability, right, within the model, controlling hospital cost growth, but we've also done quite a bit of advancement in terms of improving some really important quality measures as well. The biggest one being reducing readmissions within the state. That was just a huge endeavor, particularly early in the model, and really the hospitals in Maryland knocked it out of the park, right? Guaranteeing equitable funding of uncompensated care. I'm going to come back to this in a moment, but this is hugely important. Stabilizing hospitals in order to ensure access to care. There has been some real benefits to kind of smoothing out some of the hospital finances during COVID, during the COVID years. Equalizing hospital charges for all payers. I'll come back to this one as well in a moment, because I think when we translate that to what it practically means, it's hugely important. And then again, supporting population health and health equity objectives. We've delivered to the federal government under this model. We've done the things that we were required to do, right? We've reduced the cost of healthcare relative to national trend. We've improved care quality. Again, we've done a lot of work there. We're advancing rural health. We've had fewer rural hospital closures kind of per capita in this state. We've preserved patient choice. Maryland has had a lot less hospital consolidation than surrounding states. And we've been able to emphasize really prevention quite a bit more, under this model than many states have been able to. Just reflecting on where we've been, this model really came about over 40 years, but it's been really in the last 10 years, the last decade, where a lot of the kind of innovations have come about, right? So certainly that's been driven a lot by hospital global budgets, but again, engaging physicians, engaging physician practices into the model has been important. So let me go back to a couple things, because I do want to highlight from a healthcare financing perspective, there have been some really important aspects, not just of the total cost of care model, but just going back decades, right, for the Medicare waiver that Maryland has enjoyed over time. One is that the flexibility that we've had with Medicare hospital payments has enabled us to set up our uncompensated care fund, which is what our agency assesses from hospitals. We increase all hospital rates, we assess that back, and then we reallocate it to cover bad debt at hospitals, right, for uncompensated care. That's been hugely important over the years, because we do not then have safety net hospitals, right? So hospitals get essentially covered their fair share of uncompensated care throughout the state. So that's from a healthcare financing perspective, really important. Equalizing hospital charges, that's really been a tremendous aspect of this, right? Our Medicare and Medicaid patients can walk into any hospital, right, in the state. The payment that hospital receives is about 20% higher per case, right, than other states receive. Why is that important? It's vitally important for the hospitals that see a higher mix of public payer patient mix, right? So Medicare and Medicaid patients. Many of the hospitals that you all represent see upwards of 60 to 80% in some regions of the state. So that enhanced per case payment is extremely valuable. The federal dollars that come in from that number in the billions, if that were to reverse out suddenly, right, that would be incredibly hard to overcome, at the statewide level, but particularly for those hospitals who see predominantly Medicare and Medicaid patients, of which there are many in the state. So there are a lot of important reasons why we are pursuing the AHEAD model. And when I say pursuing the AHEAD model, let me give you a sense of where things stand at the moment. So, as I said, the federal government is looking for changes with the AHEAD model. It's not just for us, it's for all states, but it's especially impactful to us, right? Because we are deeper into hospital global budgets. We have had that kind of differential payment for Medicare and Medicaid over the years in Maryland. So we have a little bit more at stake than many of the states who are anticipating joining the AHEAD model. There are currently three kind of areas in which we're negotiating with the federal government. One is essentially the savings target, right? So in other words, when we're in this model, there's going to be an expectation that we reduce cost growth for Medicare total cost of care on a per capita basis to some degree, right, relative to nation. That is a hugely important number, right, because we have to have a pathway, right, to be able to drive those savings. So that is one, maybe the biggest aspect of this. The second area is really how much flexibility are we going to have as a state to manage global budgets, right? As I mentioned, uncompensated care fund, right? That is something that we operate kind of at the state level, and we need to have flexibility to do that kind of, that dance of increasing the rates, pulling the rates back, reallocating to cover bad debt. That is a flexibility that we really need to have in order to maintain some of the really important benefits of the model going forward. So we're exploring that as well. The third area is really timelines, right? So implementing changes, whether they are changes to quality measures or implementation to the way that payments are made, right, takes time. We've been kind of in this model for a while, hospitals in particular, but also primary care practices, other physician practices can't be expected to pivot immediately at the start of this model. We need to make sure that we're not getting cliff effects, right? As we move from one a set of rules to another set of rules, right? It has to be smooth and it has to be over time. I'm happy to report that on that area, we're getting a lot of traction. I think the federal government, through a lot of work on the state's part, a lot of work on the part of our stakeholders, including our hospital partners, have really done a good job articulating the importance of timeline, right, for and implementation timeframes and what is feasible and realistic. So we're getting a lot of good traction there. What we're anticipating is really minimal changes in 2026, possibly as well in 2027. This is not locked in stone. So please, please, please do not walk away thinking that all is locked. But that is the way that things are trending, right? That's great. That's really important. But those other two areas that I've discussed here, they really are critical areas that you are likely hearing from your hospital leadership. They are all focused on that and working with us on that as well. So when will we have more certainty about this, right? We are kind of in the midst. I would expect that we'll have more certainty early in the fall here. But we have a long way to go in order to kind of get a better understanding for what the federal government, what our federal partners are looking for. So there's more to come. Again, I think the timelines help us, right? And no guarantees, but a little bit longer time to implement, certainly helpful. But we are all urgently working toward getting clarity on what this model is going to look like going forward. It's certainly important to all of us in the state. So let me pause there. I know, Dr. Forrestal, you thought maybe 15 minutes and then save the majority of the time for Q&A here. So let me take down these slides. I know there's a lot to discuss here, so I'm anxious to get into it.
Okay, so very good. Thank you very, very much. Excellent presentation. We have a couple of questions coming in. If you want to raise your hands or just text it, and I will ask for you if you don't want to. But our first question that we had was, what are the expected savings? What would the impact on reimbursement be, especially regarding the emergency department?
Yeah. So we don't yet know, right? Let me talk about the emergency department aspect of it, though, because we within the kind of global budget framework have never set service line distinctions about the global budget, right? So in other words, when the global budget is established, we inflate all costs, right? We inflate volume across the entire hospital. We don't do it targeted at each kind of line of business within the hospital. I would anticipate that would not change, right? So in other words, a hospital would have quite a bit of flexibility about what aspect of their hospital to invest more in, drive more cost savings, et cetera. That's always been the case, and I would anticipate that it would continue. And come back though to that. I think the main part of that question though is, what is the savings expectation going to be? As I said, that is really a major aspect of this negotiation. We need to see where that's going to land and whether it's how will we achieve it.
Okay. Is there anything else you want to say on that? Or I'll recognize Mr. Myers or Dr. Myers.
Sure. Yeah. Dr. Myers. Yes.
Okay. Thank you. I know the AHEAD program has been sort of in the development stages for quite a while now. And I'm wondering what the impact of the big, beautiful bill is having on what the original plan was versus has it been modified with all these changes to Medicaid and rural hospitals and everything else?
Yeah. Yeah, such a great question. It's a really critical question because the AHEAD model, yes, it was developed well before before HR1, and I think the federal government and we certainly at the state level appreciate that. Hey, the context now is that we may have potentially higher degrees of uninsured patients here in Maryland, right? Um, there are certainly less tools in the Medicaid toolbox to direct funding towards specific hospitals. And then third, I would say, we're going to potentially be entering a period of time here where other social services are reduced as well. So many of the patients that you see may not have access to SNAP benefits, et cetera, right? So all of those things together, I think, tell us, hey, we're heading into a period of challenges from a population level in terms of delivering good patient care. So I think that is part of, Dr. Myers, what is driving kind of the recognition that a longer implementation timeline is necessary. So that's good. I do also know that the federal government, as part of the package, announced that there will be a rural health program. I think that's particularly important. The rural communities rural hospitals tend to serve communities that have higher Medicare and Medicaid populations, so they're going to be more impacted. So we are working to figure out how we as a state can take advantage of those funds and make sure that those funds are directed to our rural hospitals. I think that's going to be a real important effort over the next a few months.
Okay, Dr. Myers, do you have any follow-up?
Well, I do, but I'll let you have other people speak.
Okay, very good. Dr. Bond.
Sorry, coming off mute and highlighting myself. You mentioned in your talk that the current model has increased insurance competition, but I've heard over the years it actually has limited insurance competition. And in my mind, I feel like there's only Kaiser, Care First, and some United Healthcare. There's lots of the MCOs that are all just Medicaid products. But I'd love to get some more insight into how this increased insurance competition in our state, because I feel like there's a monopoly with Care First.
Yeah, so there is certainly a dominant carrier here in the state, but over the years, particularly following in the individual market, the 1332 waiver that the state applied for, that really helped to stabilize rates. So the stability of the hospital trend plus the stability of kind of backstopping the adverse selection has brought in some other carriers into the state. So Aetna's in, Cigna's in. Now, that does not mean that they will stay in, as Dr. Myers suggested. HR1 also has some real challenges for the individual market as well, right? So, I think under the model, the stabilizing aspect of medical trend has helped bring carriers into the market. But I would certainly say that that is not the only factor. And Dr. Bond, my hope is that they will stay in the market and grow market share. But we'll see. We'll see.
Okay.
And if I
Seeing
could
no
ask
other
a
questions.
follow-up, Carrie,
Please.
if that's okay.
Oh, yeah.
I feel like the current model has definitely benefited the hospitals. I know my hospital sees over 60% Medicaid, Medicare, and they get the same rates as Care First. But it doesn't seem like the physicians were in the first model considered very much. Like, I don't get as much as the hospital, and it seems like a lot of hospitals actually subsidizing physician practices to try to keep them even. So since we're Maryland ACEP and we're emergency medicine physicians, how would this new model make us whole or help us increase our lifestyle, at least keep us up with COLA, the cost of living?
Yeah. Again, a great question. And I think this is an area that, given flexibility, is an area that we're hoping to explore, right? And I'll kind of just describe kind of root cause challenge here, right? So for essentially the entire time that that Maryland has had hospital rate setting, physician costs have been held outside of regulated rates, right? And I think that's well known to everyone. You know, over time, and we've talked about this in public meetings over the last years, over the last year. We've recognized that over that same amount of time, so essentially the facility fee for the hospital has been regulated. That has gone up with inflation and with population growth, particularly the Medicare pro fees, right? Those have lagged, right? And I think that's well published, published, and many of you, I think, have studied that or experienced that. So that lag kind of earlier in the model, right, could be compensated for, right, by the subsidies that you described. As the lag gets greater and greater, it becomes a bigger challenge to fund. So I think we are at a point where we've done a lot of work on cost reporting for physician costs, even though we do not regulate physician costs. We want to have a better understanding of the costs that a hospital kind of supports for hospital-based physicians in particular. So that's the effort that we're undergoing now, is understanding how much of a cost driver that is for each hospital. Again, in large part due to the inadequacy of the Medicare payments for physician fees. We're trying to get apples to apples comparisons across each hospital. That's a little trickier than it seems, because different hospitals kind of or different health systems account for those costs in different ways. But once we have an understanding of the variance across the state, our hope is that we can come up with some policy solutions to mitigate that and then control costs in the future as well. But again, that is dependent on us having some flexibility, right, to manage hospital global budgets going forward, right? And so our hope is that we've been doing this hard work. We're closer to a solution than we've been in a long while. And if we have the flexibility going forward, then we can progress as a state to figuring that out.
Okay, Mike, any other follow-up?
Give the floor to others at the moment.
Okay. Seeing no other questions, I'll ask the second of our questions that we came into this with. You had mentioned several times about state flexibility and about protecting the safety net. And that's certainly a great thing. I don't know if you can answer this question, but how much of a priority are they making it in these negotiations to protect the safety net hospitals? Is that high on the priority list, or is it a lip service kind of, yeah, we'll take care of them, but with no real priority?
Yeah, I mean, I don't know. So I think within the methodologies that they are considering, and I will say considering because they've been developing them for a while. They are not completed, right? There are a number of adjusters for things like, as an example, social need, right? So the social needs of the population or the patient population of a hospital can trigger an adjuster to their global budget. That's certainly helpful, right? I think the question is, when you design a policy that is essentially for all hospitals across the nation, you have to be really careful that you've built that adjuster on the right comparator data, et cetera, right? It's tricky to do at the national level, right? So our hope is that, one, they'll do a great job, and then two, we might have some flexibility as well to help bolster, hey, when we see a hospital taking on a greater share of cost burden, that we have some mechanisms to deal with that.
Very good. All right, Dr. Myers, you had gone once already. We're going to let Dr. James go, and then you.
Yeah, sure.
Oops, sorry, James, I remuted you. There you go.
Thanks, Gary. Appreciate it. It's Jim Williams. John, thanks very much for taking the time to discuss this with us. I wanted to ask 3 questions. I know it's complicated, but I really want to get some insight into this. So you mentioned that there's savings throughout this program and its existence. And the question is, the savings is for whom and how is that savings distributed? And number 2 is, what is this model compared against? You said it's successful, but what is the comparator? And if it's been so successful, why are we still the only state in the country that has this model? And then number 3, the concern I think with all of us is Maryland ACEP chapter is we're really the only unfunded specialty that has the unfunded mandate to see patients. And as you know, emergency medicine, we're an outpatient service, we're not inpatient. So in some way we're divorced from the hospital. And the hospital might save money or they might gain financial attributes because of this model, but it's not necessarily passed on to the emergency physicians. And more to the point, we're held liable for taking care of the patients without any of the benefits of this program. And so all those are 3 significant points, I think, for this very program's existence and continuation. So yeah, thanks for reviewing those. I appreciate it.
Absolutely. Great questions. So one on what has driven the savings and how are they counted, et cetera. I will say by and large, the savings have been driven by a couple things, right? One is, I would say that this is this is certainly the type of savings that I would love to see more of, right? Which is the prevention of need, right? So population health. We have seen a lot of investment in care management and care coordination over the years, and we've gotten some traction, right, in terms of preventing certain types of condition and preventing the progression of some chronic conditions. So that's certainly been helpful, and again, something that I think if we can get to a place where we have a coordinated statewide kind of plan for population health, hopefully we can drive more of in the future. A lot of the savings, though, over the past decade really has come from shifts in site of service, right? So there have been particularly a lot of surgical cases over the years that have shifted from hospital settings to ASCs. So we've seen a lot of that. One of the very, very biggest kind of types of volume that have shifted out of the hospital, and frankly, I think this is pretty beneficial because the trend has been the opposite in the rest of the country, is drug costs, right? So I'm not talking about, oncology treatments and things of that nature. That has trended about the same as the rest of the country. Really, I'm talking about lower cost drugs that in many parts of the country, hospitals bring in to the outpatient setting. Here, it's really done in the physician's office or elsewhere, right? So those are examples of where essentially site of service changes have driven quite a bit of savings within the model. So that's where a lot of the savings have been driven. There are some more minor savings generated from essentially conversions of hospitals to other types of facilities as well. There have been a number over the years. Umroy, for example, is in the process of transitioning now. So when that happens, there's usually a little bit of savings to the system when that occurs. But again, by and large, the biggest driver of savings has been that reduction of hospital utilization. To whom do those savings accrue, right? It is shared. Some of it goes to payers, and certainly what Medicare's expectation is that some amount of that goes to reducing Medicare costs, and we've met those targets. Some of it goes to Medicaid, some of it goes to commercial. Again, this is not straight savings. This is a reduction in cost growth, right? So we are just essentially growing slower than the rest of the country. So we call it savings, but I want to be technical there. But some of it is also remaining with the hospitals and the physicians that participate in the programs as well. So it is really a shared savings environment. I think the last question that you raised about emergency departments, I think this is a great point. So up to this point in the model, and when it originated, we were across almost all types of volume, all lines of business within a hospital, a very high volume state everywhere in the state, right? We were seeing higher volume than national average, inclusive of emergency departments, right? So at that time, it was really the imperative of the model to kind of incentivize reduction in volume. I would say that now we are at the point where we've seen a lot of that reduction in volume, and we have to get a little bit finer grained about where we are expecting further reductions in volume, and where, hey, we might have hit the limit and we may actually even need a little bit of capacity growth, right? We have done a couple things, and that is both regional as well as essentially by service line, right? It's not constant, uniform across the state. So over the last 6 months, and actually just yesterday, we've approved, for example, some increases in rates that are pegged to the amount of respiratory volume that hospitals see. That is really meaningfully impactful to the EDs, right? Because if you're essentially funding the volume that couldn't be prevented during flu season and COVID and RSV, that's going to kind of financially depressurize the hospitals that, when we look at the data, typically have particularly large emergency departments and large volume of patients coming through the emergency departments. So it's a little bit targeted to the high ED volume hospitals. Obviously, that's largely because that respiratory volume is principally coming through through the ED. So that's an example of where I think at the start of the model, we didn't have a whole lot of tools for doing that kind of finer grained look at what needs to increase versus what needs to decrease. And we're starting to evolve in that direction, right? Again, this is where, our hope is that under the AHEAD model, we could continue to do that, right? The other area where that exists is, hey, we're in a mode now where year over year, we do inflate global budgets based on demographic projection, demographic growth in the in the state. But we also have some regions that need to kind of take down or retire kind of unused beds, right? And you take out that capital and you take down that fixed cost. And then we have other parts of the state that have to, grow in their capacity. And so we've done a couple things over the past year to help some hospitals with certificates of need who are growing beds to cover the higher operating costs associated with not just bringing a patient into an existing bed, but I've got to grow a whole new bed, right? So I have to hire all new staff, I have to hire new physicians, I've got to build the thing, build out the room, et cetera. So we've done a couple of those initiatives, and that's on a case-by-case basis, right? We've done a couple of those initiatives, and the hope really there is particularly for those hospitals, really improving their throughput, and then I think in one hospital we're already seeing a little bit of drop in ED length of stay. So the hope is that by getting more fine-grained with these policies, we can really start to tackle some of the things that are pressurizing our EDs across the state.
Very good. Dr. Myers. There we go. We'll get you unmuted.
Okay, thanks. Yeah, your last comment about the ED length of stay was one of the things I was curious about, how much consideration was given to that in the AHEAD planning. A year ago when Dan Morheim and I were writing about this, we were number 49, or no, we were number 50, and Washington, D.C. was number 51 on the bad side of ED length of stay. And so it sounds like, have you seen actual progress, or you're anticipating progress based on what you've done so far? And then I do have a side question, which is, a year or so ago, Jesse Pines wrote an article about setting up physician compensation via a global budget model. And I wonder if any consideration was given to that in your deliberations as you're planning the AHEAD program.
Well, geez, Dr. Myers, you're going to get me in trouble with Gene, I think. but let me answer both of those questions. So to be frank, I would say ED length of stay efforts are ongoing. I would anticipate improvement. We've certainly seen some improvement, and I'll break down kind of the different kind of channels, right? Because it is a multifactorial challenge that we're facing here. So what we've done over the past year, and I would also say, look, this has been a multiple decades long problem, ED length of stay. What we've done is kind of really broken down the challenge into a couple components. We've been doing some, for the last year, some ED best practice work with our hospital partners. We've incentivized participation in it. We've gotten a lot of collaboration. We've seen hospitals adopting some of those best practices, and there is some lift. I would say that this is important, but it is not the biggest bucket. You all know better than anyone, right? Every ED can improve their efficiency, but by and large, EDs are pretty efficient places, right? So there's only so much you can wring out of that. The much bigger, I think, effort, right, is and a little bit different than kind of previous efforts within the state, is really to focus on throughput, right, and throughput on the upstairs floors. So we're in process of collecting a lot more data and really kind of getting to root cause for our throughput challenges. The department has been a partner in that, and they're doing what they can do to eliminate some of the kind of long stay patients that are challenged by, for example, behavioral health placements in Medicaid and so forth, right? So that's important. Again, those are small numbers of patients. We see that there is a lot of best practice work that can be done at the hospital in terms of discharging, right? So there's certainly length of stay efforts, initiatives that hospitals can do. But then also there are, I think, real meaningful challenges with, for example, getting patients discharged to SNFs, right? We've identified that as a major driver in the growth of inpatient length of stay over time. So I think over the last year, we've done a lot of good root cause analysis. We've made some progress on the low-hanging fruit, but over the longer term, we're really going to have to tackle some of the kind of coordination and discharging to other settings, right? If we're really going to solve this problem once and for all. So, I think Dr. Myers, we've made some progress, but there's a long road ahead of us.
Okay, Mike, you had a follow-up.
I did. I have two questions, and the one, I don't mean to be antagonistic, but does the HSCRC actually represent physicians, or is it all just about the hospitals?
So, I would say that we represent all Marylanders. And, I would say while we don't regulate physicians, we actually do quite a bit of work on physician-based initiatives, right? So, the EQIP program, for example, is something that was really designed to get upside value-based payments to physicians to get aligned with some of the things that would reduce costs and hospital costs, right, by avoiding utilization. That's been a really successful program in terms of the number of physicians participating, the bundles that have been created, and the savings that it's generated. For the size of the program, it actually generates, about $30 million, right, in savings. So it's really an example of where I think we could go in the future, get more of those alignment type programs where we're sharing in risk, we're sharing in savings, and building that type of alignment. I think we also do a lot of quality work. We have about 7% of revenue is tied up in some sort of quality or performance-based incentive. In most of those initiatives, we really rely on our clinical partners to help us drive and identify, hey, what are the right targets, right? What are the right things to focus on? We tend to really rely quite a bit on the clinical expertise in the state, particularly physicians, to help us design those initiatives. So, our hope here is that we are getting better and better alignment between what works for physicians in the kind of clinical practice and how does that pull through to better care, and that better care gets to better savings.
So if I could, I know you have a second question, Mike, but I've got a couple of people coming in on the
That's
chat
fine.
to make a point that I think Dr. Williams is about to make. And they really want to hammer the point that ER, we call it ER boarding. I'm going to kind of accumulate the chats. We call it ER boarding and ER throughput, but really this is a hospital-based problem. This isn't a problem with the ER. It's a problem with resources, getting people, as you said, discharged and so forth. And I believe Dr. Williams, is that what you were going to discuss? Because you were one of the first voices, so I figured I'd give you first crack.
Right. And again, this is where I understand it's challenging trying to break out service lines. But again, the ER it is the only place really where patients these days go for acute unscheduled care. The family physicians, they don't have the means or resources, nor do any of the specialists for that matter. So the default is go to the ER. And we're the only unfunded group by the EMTALA, the only unfunded mandate. So the hospital has an incentive to keep people out of the hospital because that's how they're measured. So my concern also, you just mentioned shared risk. That's one of the things I would suggest most of my colleagues would say, that's not really so. We're bearing a lot of the risks because we're the ones tasked with saying, hey, they can be discharged safely. Well, if they can, so what? We can't get them in the hospital. I can't get a patient admitted to the hospital until I talk to my case management. And they go through whether it's Optum or another database to say they meet criteria. And so if the patient, one would think that they have the motivation to have good health care, but maybe that's not always so. So ultimately, we have to bear the burden of the patients, no matter what their presentations are, what their motivations are, what their resources are. And so that's, I think, one of our problems. And so if I can't get somebody upstairs, if they're boarding, they'll say, well, just hold them there for 6 hours. Again, we don't get OBS reimbursement for that. We take the risk of that patient. That's really, I think, what we need to do is any of this cost savings, it has to be incentivizing the hospitals to not get beds. The certificate of need is not the issue because that just gets beds, right? That is the worst term. It's got to be a staffed bed where a patient can receive care. That's what we need to decompress the emergency department. And it's only going to get worse. The ER is not going to go away because it is the only place for unscheduled care.
Okay.
Yeah, Dr. Williams, if I may, Dr. Williams,
please.
such a good point about staffing the beds, right? We got to staff the beds. We got to get we've got to limit length of stay, right? We got to get patients appropriately moved to their kind of clinically appropriate setting, right? I would not say it's only a hospital problem, right? That's why I think I've certainly made it a point to partner with the department, who has a little bit broader reach than the HSCRC, right? In terms of looking at, hey, this is really a whole healthcare continuum problem, right? It's kind of inclusive of helping to establish other community-based settings where folks can seek care instead of just only coming to the ED. Obviously, if they need to get there, we want to make sure that they're getting the best care possible. You all do a wonderful job of that. But for the folks who can be seen somewhere else, we want to make sure that we've got those resources available as well. So it is a total healthcare continuum challenge.
Okay, and Mike, you wanted to close us out with a question or comment?
Question or comment or pontification, or maybe just some insight. I think this whole GBR model has made it so that hospitals have actually shut down beds up to their GBR limit. But we know that most hospitals are maximally efficient if only 85% of the beds are full. So that way there could be some turnover and it makes it easier. Same with hotels. But the current model is heads and beds that only at midnight are counted. And I kind of laugh and make a joke all the time that if they're in the bathroom at midnight, they don't count. So it counts the model, but there's all these patients in the EDs or PACUs that are waiting that aren't counted for total hospital capacity or hospital need at times. So I really wish that time frame would be 7 a.m. because most of my patients tend to go up in the late evening hours because of discharges and stuff. But it's the midnight hour that's the only hour that counts. But there's more patients in beds at 7 a.m. than there actually are at midnight. So I think there's issues with the model, and we keep saying that we have too many hospital beds, and there's nobody on this call that will agree with you that there's too many beds in the state of Maryland, because we see how many people we're boarding. My ED probably has 5 or 6 at the time. The downtown campus of University of Maryland has sometimes 40 to 50 patients boarding, and it's only a 35-bed ED. But the hospitals are way over capacity, but still trying to meet the needs of all the Marylanders. The last part that I'm just curious about is that, and your thoughts on, I'm being asked more and more as an ED physician to do ED observations for potentially 30-day readmissions or potentially avoidable utilization. And that increases the length of stay of all these patients. So I can't turn over the bed, but the hospitals are so incentivized not to be penalized that they're asking ED physicians to do this stuff, because we will get patients out quicker than if they get admitted to the hospital. We can diurese a little bit more quickly, get their blood sugars under control, treat their COPD. So it seems like the whole model has made it so emergency medicine and the EDs are asked to has to do more and more, but we don't have the space. And then we're getting critiqued for how long our waiting times are. So not so much a question, but maybe some more insight into how the model has crushed emergency medicine physicians in caring for all the patients that come up to us unscheduled.
All right, Dr. Kromm, last word to you then.
No, appreciate the insight and really do appreciate the engagement here and the interest, right? I think my hope here is that we're able to continue the important work that we've been doing as a state. And I think your interest, your engagement, your expertise is really going to help us refine and improve the model, right? I think this has to be a living, breathing thing. It has to evolve over time. I really appreciate your insights and your help and engagement in doing that.
Good deal. So I'll close out by saying the last question we had for you was about how we're past time, so we won't do this now, but how do we as the ED have a strong voice in what's coming about with ahead? And we'll talk to you with the newsletter and we'll put something out there. I would also invite you, since I know this is an evolution and it's a very fast evolution after HR1, if we could invite you to come back in the fall and kind of give us an update after we've had our conference in another town hall, so we have an idea of what's coming our way.
Would love to do that. Would love to do that.
Very good. And to everybody else, just to let you know, our next town hall is going to be on the resolutions to guide ACEP policy. There's a record number this year. Some of them are quite controversial. And we're going to be bringing these to the membership so that we get your feedback and guidance about what we want to do. Adriana has put our educational conference on that's in the spring. Mike, did we miss anything?
The only thing I would ask is, when do we think there might be some clarity, or is that too hard of a question?
That is a very hard question. Again, I think we're really hopeful that by the fall we'll have more clarity. That doesn't mean that all the, I's are dotted and T's are crossed, right? But we are hoping that we'll have more clarity by then.
Awesome.
Very good. All right, everybody, unless anybody has anything else, if you do, contact me, kforstall@yahoo.com, and I'm perfectly happy to make contact to whoever we need. John, thank you so much. It was an excellent session. We really appreciate your time, and we'll see you in a few months.
Thank you so much. Appreciate all of you.
Okay.
Thank you all.
Take care.
Everybody have a great night.
Have a great night.